Okay, today we're going to be talking about clinical pathology diagnostics, and we will be starting with a CBC interpretation, which is our white blood cells and platelets. So today I will walk you through one of the most valuable diagnostic tools we use every single day. It's the complete blood cell count, also known as the CBC, and it's specifically the white blood cells and platelets. So even though we look at CBCs all the time, there's a lot of nuance behind the numbers, and understanding those patterns can really elevate your clinical decision making. So let's start with the big picture. When you open a CBC, you're essentially looking at two major physiological systems. First, the immune system, which you see through the white blood cells. Second, the hemostatic system, which is reflected in the platelets. So interpreting a CBC is not just memorizing numbers, it's understanding why those numbers are changing, and that starts with the leukogram. So, the leukogram, what the white cells are telling you. A leukogram gives the total white blood cell count and the individual cell types. And from that, you can kind of piece together what's happening inside the patient. So before you trust the number, though, remember the analyzers can get tricked because there's nucleated red blood cells. So always glance at a blood smear to make sure the count is accurate. So from the leukogram, so let's go ahead and move on to the neutrophils, which they really are the first responders because they are the workhorses of the immune system in most species. Neutrophils have a short life in circulation, maybe about 10 to 15 hours. So the body has to keep a generous storage pool in the bone marrow ready to go. When you have high neutrophils, the Y matters. So sometimes it's the body is trying to fight off something, an infection, an abscess, pyometra. Other times it's not always diseases at all. Stress and glucocorticoids can cause neutrophils to detach from vessel walls and enter into circulation, making the count spike quickly. So, cats and horses, even though we're not really dealing with horses right now, but the small cats are especially sensitive to this shift because they naturally have a larger marginal pool. So now on the other side, neutropenia, so you have a less amount of neutrophils, uh, can be a real concern. So you might see it when the body is using neutrophils faster than it can produce them. So this you'll see in severe inflammation or endotoxemia, um, or it may be because the marrow simply can't keep up. Like parvovirus in puppies would be an example, chemotherapy, or even bone marrow disease. Their left shift, one of the most clinically important white blood cell clues we have is that left shift. So when we start to see banned neutrophils, that means the marrow is releasing immature cells to keep up with demand. A mild left shift just says inflammation is happening. So, but a degenerative left shift where there are more bands than mature neutrophils is a warning sign for severe systemic disease or sepsis. So we really need to watch out for that left shift. So moving down to and of course, like we talked about, there's the picture of the neutropenia in the parvo puppies. So eosinophils. Think when you think in eosinophils, you want to think allergy or parasites. So eosinophils are a little more specialized. When you see eosinophils, your mind should go to four big possibilities. allergic or hypersensitive reactions, parasites, mast cell tumors, or hypoadrenocorticism, which is also Addison's disease. So, and sometimes it's just idiopathic, especially in Rottweilers and cats. So, idiopathic, we don't know why. On the flip side, eosinopenia, so not enough eosinophils, is more often associated or just part of a stress response. So, whenever cortisol levels rise, eosinophils tend to drop. So, moving on to basophils, um, they're rare, but they are meaningful. So basophils don't just show up very often, but when they do, they tend to follow the same trends as eosinophils, particularly in hypersensitivity and chronic inflammatory conditions. They're rare, but not irrelevant. So lymphocytes, um, their adaptive immunity at work. Sorry. Lymphocytes take center stage in certain species, but in all species, they're essential in adaptive immunity. Most lymphocytes we see are small, mature cells produced in lymphoid tissue, like the lymph nodes in the spleen. So at lymphocytosis can mean several things. It can mean a chronic infection, a physiological response in a stressed or excited animal, or something neoplastic like chronic lymphocytic leukemia. Lymphopenia, again, not enough lymphocytes, however, is one of the hallmark signs of a stress leukogram. So when cortisol levels rise, lymphocytes fall. And then we have reactive lymphocytes. These are slightly larger cells with deep blue cytoplasm that signal immune activation. They're an important there's an important distinction. Reactive lymphocytes show an active immune response, whereas lymphoblasts raise concern for leukemia. So that's really the distinction between the two. So make sure to keep that in mind. It is an important factor. Amazing. Move my notes aside. So let's move on to monocytes. They are the chronic inflammation indicator. Let me move that up a little bit. So monocytes are the precursors to macrophages uh, and show up when inflammation becomes more prolonged and chronic. So you remember our neutrophils, our first responders. The monocytes come in when it becomes more prolonged. So monocytosis can accompany inflammatory disease or be part of a classic glucocorticoid response, particularly in dogs. So you'll see, patterns you'll see over and over again. One of the most valuable aspects of the CBC is recognizing these patterns rather than focusing on individual cell types. So the stress leukogram, is driven by cortisol, either endogenous from illness or fear, or genius from steroids. So it's either from inside your body from fear or illness, or outside from chronic steroids. The pattern typically includes neutrophil and lymphocytosis, and that's in cats and horses, typically. Whereas the pattern, particularly, neutrophilia, lymphopenia, eosinopenia, and sometimes monocytosis are more dogs, especially in dogs. And then you have the physiological leukogram, which is comes from that surge that is classic in nervous cats and horses. And in the vet clinic, cats are always nervous. So you'll see a neutrophilia paired with a lymphocytosis, which is a key feature that separates it from a stress leukogram. So I can't stress that enough. It is the key feature to separate the two. So inflammatory leukogram is, let me move my screen. This is where neutrophils rise because there's a true inflammatory process. You may see a left shift, toxic changes, monocytosis, and sometimes lymphopenia or eosinopenia if inflammation is severe. So now we're going to talk about platelets or thrombogram. This is the first step in hemostasis. Now, the thrombogram is the platelet portion of the CBC. So platelets are small, but absolutely essential for primary hemostasis. The normal platelet ranges vary by species, but as a rule, spontaneous bleeding risk goes up significantly once platelets drop below about 30,000 per microliter. Thrombocytosis is usually reactive. The body is producing more platelets in response to inflammation, neoplasia, or immune-mediated disease. True platelet neoplasia is extremely rare. So when you're thinking about that don't jump right to neoplasia because it's not common. Let me see. Thrombocyte Cytopenia, however, requires some attention. Low platelets can be due to immune-mediated destruction, consumption during DIC or vasculitis, or decreased production from bone marrow disease. And don't forget the common trick the CBC plays on you, platelet clumping. So, uh, especially in cats and horses. So again, go back to that blood smear because if the platelets are low on the bloods or on the machine, there's a good chance there's platelet clumping. So a falsely low automated count is common. So again, it's critical to look at that smear to get the whole clinical picture. Um, so, kind of some keynotes, bringing it all together. When you look at CBC, don't think of it as a list of numbers, as I mentioned prior. Think of it as a story, a story about the immune system and how it's reacting, how the body is handling inflammation, and whether the patient might be bleeding or clotting appropriately. The white blood cells tell you what's happening right now. The platelets tell you if the body is prepared to respond to injury. And I think those are the big take-home messages. The patterns tell you again the why behind the numbers. When you combine all those pieces, the CBC becomes one of the most powerful diagnostic tools we have. Not because of the data points themselves, but because of the meaning behind them. So I hope that helps to get a better understanding. And we can move on to the next lecture. Let me pull it up. I think it's, yeah, part two of the clinical pathology diagnostics. Let me see. Let me go back to the beginning. Time is, okay. So All right, so now let's shift into the red blood cell portion of the CBC. This is really where we start thinking about oxygen delivery, anemia, and overall bone marrow function. I like to describe the CBC interpretation as a bit of a diagnostic detective work. Each number gives you a clue, but it's the patterns that really tell the story, as we talked about in the last lecture. So, where CBC, where red blood cells come from? A quick, so let's go give a little refresher. All of all of our blood cells, whether they're red blood cells, white blood cells, or platelets, originate in the bone marrow. That's the main production site. Stem cells, there can choose different developmental pathways, I would say. The myeloid line for many white blood cells, the erythroid line for red blood cells, and the megakaryocytes for platelets. So I hope that's not it's a mouthful, but hope that makes sense. So, and while the liver and spleen can help out a little, especially in times of high demand, the marrow is the primary engine behind blood cell production. Cytokines and stromal cells guide these stem cells into becoming exactly what the body needs. So, here we go. So, how red blood cells are made. Red blood cells production is driven by erythropoietin, which is produced by the kidneys in response to low oxygen. That's why kidney disease often leads to anemia. Without erythropoietin, the bone marrow simply doesn't get the signal to make red blood cells. As red blood cells mature, they go through several stages. Early, they're nucleated. You'll hear them called rubricytes. The last stage before becoming a mature red cell is the reticulocyte, which still contains some RNA. So reticulocytes are incredibly useful because they tell us whether the bone marrow is responding to anemia. One important species difference is horses don't release reticulocytes into circulation, so you won't see them even if anemia is regenerative. So remember that about horses. It's super important. That's the only species you'll be focused on. So, red blood cell structure and damage and lifespan. So, red blood cells are designed to be flexible. Their cytoskeleton helps them squeeze through tiny capillaries. What When that structure gets damaged, you start seeing oddly shaped cells um, eh, um, when those walls get damaged. So oxidative injury is another thing to keep in mind. When red blood cells are exposed to oxidative stress, like toxins, like onions in dogs or acetaminophen in cats, you will see Heinz bodies, which are clumps or denatured hemoglobin inside the red blood cell. So Heinz bodies, when you see them, they are very you know it's mostly a toxin, and in dogs it's onions, and in cats it's acetaminophen. So usually, but they're a telltale sign. So red life or RBCs lifespan varies by species. Roughly 2 months in cats, 3 in dogs, about 5 in horses and cattle. The spleen plays the cleanup crew, removing all old cells and recycling iron. So hemolysis has two different pathways. Let me see if I'm. Hold on. Sorry. I wanted to. I think I will. Oh, here. I'm sorry about that. Oh, here we go. So, When red blood cells are destroyed, it can happen in two places. Intravascular hemolysis happens in the bloodstream. You'll often see free hemoglobin. Think about conditions like babesia or anaplasma. Or it can happen extravascular. And as you can see, oh, and you can see the babesia in that one slide below the extravascular. And so extravascular hemolysis happens in the spleen or the liver. This produces bilirubin, and you can get prehepatic icterus. So, of course, you get the yellowing. Immune-mediated hemolytic anemia and equine infectious anemia are great examples. Understanding which pathway is happening helps you figure out the underlying cause. So here's two great pictures. Um, and see, you can see in the second picture the normal nucleated red blood cell. And this was on a snake's blood smear. Um, So interpreting the blood cell portion of the CPC key parameters. Let's kind of walk through the major red blood cell indices and what they actually tell us. So we have, let's start with the hematocrit, also called the packed blood cell volume. Um, these give you the percentage of blood made up by red cells. So, PCV is the direct measurement from centrifuged blood, and the hematocrit is calculated. I hope that makes sense because it can be a little bit confusing. So high values are usually dehydration, splenic contraction in excited horses, or true polycythemia. Low values, though, on the other hand, mean anemia and in rare cases, overhydration. So you'll see a lot of increased hematocrit in when they're not hydrated enough. That's the most common one we see. So hemoglobin, hold on. So, and you can see it in this picture, the hematocrit on a canine when you after it's been spun down and measured. And you can see the icterus, obviously, with the yellow. So, hemoglobin, using usually about a third of the hematocrit is hemoglobin. It's measured directly, but can be falsely elevated by lipemia, Heinz bodies, or lots of nucleated red blood cells. The mean capsular volume, the MCV, this tells you the average size of the red blood cells. Large cells, macrocytosis is what we call it, point to regeneration. Feline leukemia infection in cats, or B12 or slash folate issues. Small cells, on the other hand, microcytosis, often means iron deficiency, younger animals, or breed tendencies like Akitas. Am I on? So iron deficiency. Um, so if the I don't think where am I here? If so the MCH and MCHC. Um, the MCH isn't very clinically useful on its own. So MCHC, though, helps identify hypochromic cells, usually from regenerative anemia or iron deficiency. If MCHC is increased, it's almost always an artifact, like in lipemia or hemolysis. And here's a little picture of anemic piglets associated with that iron deficiency. Oh, sorry. So moving on to red cell distribution width, or RDW, it measures variation in cell size. When it's increased, it usually means you have a mix of larger and smaller cells, which happens when bone marrow is actively regenerating. So, looking at regeneration, reticulocytes are one of our best markers of regenerative response, except in horses. Horses seem to be the exception in a lot of things. If the reticulocyte percentage is higher than expected, the marrow is trying to compensate for anemia. You can also see nucleated red blood cells in regenerative anemia or bone marrow injury, but they can artificially elevate the white blood cell count, so corrections need to be may be needed. But keep it in mind, it could be artificial because of the white blood cell count. So, some key clinical patterns to think about. When you're diagnosing anemia, think in terms of um, mechanisms, um, blood loss, internal or external, hemolysis. It could be immune mediated, infectious, or toxin induced. And then you have production failure, bone marrow disease, chronic illness, renal failure. And here, these pictures, you can see increased reticulocytes is an indicator of regenerative anemia in all species except horses, like we talked about. But here's two pictures, and you can see where the arrows are. And then some final takeaways. When you interpret the red blood cell portion of a CBC, always combine the indices with the blood smear and clinical picture. Remember that blood smear because your machines don't always, like anything else in clinical practice, do not rely on your machines. So red blood cell shape, regeneration status, and species differences can completely change your interpretation. And that ends our red blood cells part, except for I guess the last thing I would like to add though is that so when you're reading the numbers, always ask yourself, is the bone marrow producing normally? Are the red blood cells surviving normally? Or is something causing them to be lost, destroyed, or not produced at all? I don't know what time. So we can actually, we have time to move on to the serum biochemistries. Let me, here we go. So we're going to look at serum biochemistries, electrolytes. So all right, let's when we're shifting to electrolytes, one of the most foundational parts of serum biochemistry, and honestly, one of the most clinically useful, is the electrolytes. Electrolytes are like the electrical wiring of the body. Let me move this up. They control fluid balance, nerve conduction, muscle function, and acid-base status. And when they're off, even a little, patients can get into trouble quickly. I always tell students that interpreting electrolytes is a lot of detective work. The pattern, not just the number, tells you the story. Just like the other things we've talked about. It You can't just look at that number. And if you ever want great visuals, eClinPath is a fantastic resource. So what are we looking at? When we talk about electrolytes in the chemistry panel, the main players are sodium, potassium, and chloride. And then we have the minerals, calcium, phosphorus, and magnesium, which tie into everything from neuromuscular function to kidney disease to hormone balance. So you can see why electrolytes are so important. So sodium. This is the hydration gauge. Sodium is a big extracellular application. Whenever sodium goes I'm sorry, wherever sodium goes, water follows. So sodium, that's why, when you eat salt or have salty food, you're thirsty. It's same in the body. So sodium levels are basically a reflection of extracellular fluid balance. So hypernatremia, so an increase in sodium when it's high, the most common reason is actually water loss, not sodium gain. So I hope that makes sense. So it's water loss, not sodium gain when you have low sodium. Think GI losses in dogs and cats, diarrhea in large animals, animals without access to water, or CNS issues affecting thirst. So salt ingestion can do it too, especially in calves. And we talked a little bit about that, ingestion of salt. So looking at hyponatremia, so decrease in salt or sodium, I should say. So low sodium is usually about losing sodium-rich fluids or diluting the sodium with too much water. You see it in DKA, severe GI diseases in horses and cattle, and hypoadrenocorticism, which is also Addisonian, and with diuretics or volume overload. So here's the key safety point. If you correct chronic hyponatremia too fast, especially more than zero point 0.5 micro equivalents per liter, or per hour, you can cause severe neurologic injury. So slow and steady is the rule. Otherwise, you're going to have CNS problems. So make sure it's done slowly. Um, s- s- so here's a cattle with hyponatremia, and because of due to diarrhea. I don't know if I can click to enlarge. So moving on to potassium, this is like the electrical signal. So potassium lives intracellularly, and so even tiny changes in plasma potassium are significant. It's crucial for neuromuscular and cardiac function. So an increase in potassium or hyperkalemia, this is can happen in hemolysis, thrombocytosis, or using the wrong tube. But true hyperkalemia makes me think of urinary obstruction, uroabdomen, so you have urine inside the abdomen, acute renal failure, especially when the patient is oliguric. Oh, and then Addison's again. We go back to Addison's disease in dogs, HYPP in horses, massive muscle damage, or neonatal diarrhea in calves. So acidosis will also shift potassium out of cells. Then, if we take a look at the other side, hypokalemia, uh, when potassium is low, you want to think poor intake. It's common in large animals that are anorexic, or think losses like CKD in cats, so chronic kidney disease. Loop diuretics can cause it. GI losses, sweating in athletic horses is also a reason. Insulin and alkalemia shift potassium into cells. We also see postpartum hypokalemia syndrome in cattle. So there's you have that the picture of the uroperitoneum due to urinary bladder rupture, as you can see here. And of course, that's like we talked about, developing severe hyperkalemia. So chloride, I kind of think about that as sodium's partner. So I always interpret chloride alongside sodium. The two usually change together. If they don't, that's your acid base clue. So when sodium and chloride change by the same amount, think simple free water shifts like dehydration or overhydration. When sodium and chloride diverge, that's when you start thinking acid-base disorders or selective chloride loss. So let's take a look at hyperchloremia. There you go. So, oh, and often related to the hyperkalemia, it's often related to medications like potassium bromide or hypochloremic metabolic acidosis. But a decrease in chloride is usually um, due to losing chloride-rich fluids. So in small animals, that often means vomiting with gastric outflow obstruction. In cattle, think they also too, it's an outflow obstruction. And then in horses, think gastric reflux, or salivation, or severe diarrhea. Now, moving on to calcium, there's three forms: free, bound, and complex. So total calcium is a combination of ionized calcium, protein-bound calcium, and a small complex fraction. So the ionized calcium, or the ionized portion, is the physiological active form. That one is the one that truly matters. So if total calcium is abnormal, especially if it's dramatically high or low, check an ionized calcium. Albumin plays a huge role here. If albumin drops, total calcium drops. But ionized calcium may be perfectly normal. So in dogs, we sometimes adjust for albumin using this formula. It's adjusted calcium equals measured calcium minus albumin plus 3.5. So when we see an increase in calcium, hypercalcemia, in dogs, the big three are for hypercalcemia of malignancy, primary hyperparathyroidism, and hypoadrenocorticism. So here is Addison's back in the picture. Cats are often idiopathic or renal disease. So either we don't know or it's kidney disease. Horses usually tie hypercalcemia to chronic renal disease. So like cats. And in cattle, it's often iatrogenic. So we gave too much of the calcium, so it's kind of on us. We can also measure vitamin D levels. Let me make sure I'm keeping it. We can also measure vitamin D levels if we're worried about toxicosis. So, if you have hypercalcemia and you're worried they got into something, go ahead and measure the vitamin D. Now looking at hypocalcemia, oh, I'm sorry. Low albumin is the most common cause, and not clinically significant if the ionized calcium is fine. So remember, ionized calcium is key. But true hypocalcemia matters in issues with pancreatitis, hypoparathyroidism, eclampsia, PLE, colic in horses, and milk fever in cattle. This can all trigger hypocalcemia. So one more detail we look at is at the calcium. I'm sorry. One more detail is that we look at the calcium phosphorus product. So calcium times phosphorus. If it's over 70, soft tissue mineralization becomes a concern, especially in renal disease. And as we talked about before, especially in horses and cats. So here's some pictures of both for hypercalcemia. So anal sac adenocarcinoma. So this is for cancerous. Um, And then there's a cow with decrease in calcium from milk fever. So phosphorus is now we're looking at it's the remember part it's the partner to calcium. So most phosphorus is lives in bone and excretion is varies by species. Monogastrics use the kidneys. Adult ruminants use saliva. So if we have an increase, oh, sorry. If we have an increase in phosphorus, so hyperphosphatemia. In small animals, it's usually decreased renal excretion. In horses, think renal disease or nutritional secondary hyperparathyroidism. Ruminants rarely get hypophosphatemia unless dehydrated. So growing animals naturally have a high phosphatemia just because their bones are growing. So top causes here of hypophosphatemia, so a decrease. It can occur with primary hyperparathyroidism, insulin therapy in DKT, chronic renal disease in horses, severe GI disease, or post partnered hypoglobulinuria, sorry, it's a lot to say, in cattle. If hypophosphorus gets too low, renal cells become fragile and can hemolyze. So here's a little kitty with urinary tract obstruction. So he's blocked and he has an increase in hyperphosphatemia. So magnesium, we kind of look at a little bit like the forgotten electrolyte. So magnesium doesn't get enough attention in general, um, but it's a critical cofactor for ATP. So most magnesium is intracellular, and total magnesium is what we typically measure. So if we have an increase in magnesium, it's pretty uncommon, but it can be iatrogenic. So, for example, horses receiving magnesium sulfate as a cathartic or calming agent, if we give too much, they'll have an increase. But hypomagnesia, so if you have a decrease in magnesium, um, this is more clinically important. We see it in critical illness in dogs and horses with heavy diuresis, in endurance horses with excessive sweating, and of course in ruminants with grass tetany. And here actually, oh, that's a lactating. Here you have a picture of that. So magnesium is often the missing piece when you can't correct hypocalcemia or hypokalemia. So supplementing magnesium can solve the problem. Just to wrap it up, when we put it all together, the electrolytes give us real-time view of hydration status, renal function, vomiting and diarrhea patterns, adrenal disease, toxicities, acid-base shifts, and neuromuscular health. The key is to look not only at the numbers again, and I can't emphasize it enough, and you'll hear me say this in other lectures, but how they move in relation to each other or in patterns. So if you can recognize these patterns, you'll catch life-threatening imbalances quickly and guide treatment far more effectively. Electrolytes rarely are one Electrolytes really are the most powerful immediate clues in the clinical chemistry panel. So I think we're at 9:20 or yeah, 9:25 my time. Sorry. And so I think our hour is up. Is there anything that further? If not, I think tomorrow's lecture we move on to serum biochemistry, energy and protein metabolism.